from preparing for RADV, obviously chart retrieval is often cited as the biggest operational hurdle. What practices have made this process more efficient?
Yes, the first step where we see pitfalls, like I think this question somebody asked is quite relevant to this one when we are answering it. One other challenge health plans face is once, because the RADVs are done so late, I mean, now that will change definitely as CMS is pushing for more frequent or complete all the audits soon. But when it comes to the charts pull, the provider systems are not holding the data longer period of time, or if the provider or the clinic is closed, they don't even have the charts or they don't even have access to the charts. As per CMS, unless it is a catastrophic event like an earthquake or a flood, you don't have an exception for not having the chart to be able to substantiate for the member. That becomes very critical, and that's where we now need to really look at the enablement of technology as well as the capabilities you have. One is how much of charts you're able to collect for the members, because if you look at it, all the members who have a HCC condition, you can identify who are your high risk members, where the conditions are potentially for an audit or capture risk. And you can actually flag those and say, I need to have a process to be able to pull those charts and keep it in-house. First step. The second process is essentially if you have EMR integrations or like access to your EMR system, as a process, you need to have a dedicated process to pull those charts, whether they are really impacting your process or improvement in your risk scores. I think beyond that, we need to look at it as a audit requirement. And that's what the health plans need to adjust or align going forward, how they can actually bring those charts early and have that information in handy. The better preparedness is very important for us when we talk about the audits to be captured. The third part is moving into more of a prospective process to pull the charts or prospective engagement with the members. Means audit can happen only when there is data where you're not known that the patient is not being monitored or managed more effectively. If the patient is being consistently managed with like active programs like AWE, annual wellness visit, PCP visits, E&M visits, which are truly capturing the conditions, then we might not have that issue. Now, can you optimize that process using some of your prospective programs so that you have a better visibility to capture? Like even if you're engaging a vendor for in-home assessments or any other type of telehealth visits, how do you make sure that you have guidelines or capture those data more accurately and report it? The last part, I'll focus more on the data quality and technology. Again, you need to be able to leverage the reconciliation as we speak about data reconciliation at all levels. When it comes in just 837 data coming in, can we identify high risk conditions and capture them? Or are you seeing any primarily like a single occurrence conditions, like only one doctor reported the condition, but no other doctor is reporting those conditions for the member? Those are your high risk members, and you always need to have the tracking in the system so you can actually be able to pull the charts and take actions on those. That is where you need combination of technology support. It's not about number of resources. Optimizing that with the help of technology, use NLP as well as integrations which will allow you to analyze the charts and close as much as the gaps as possible.